Primary Health Tasmania is supporting primary healthcare providers to improve healthcare outcomes for people with an intellectual disability. Everyone has the right to quality healthcare, to be seen, heard, and respected. Currently, people with an intellectual disability experience poorer health outcomes than the general population. To change this, healthcare professionals must understand the unique challenges and barriers their patients face. Brighton Regional Doctors is a Tasmanian practice committed to improving care for patients with intellectual disability. Their approach demonstrates practical strategies any practice can adopt. One common barrier is diagnostic overshadowing.
So diagnostic overshadowing is where the diagnosis that the patient has sort of clouds your judgment for making an accurate diagnosis. So just assuming that all the behavioural difficulties are because of the autism or something, where there might actually be comorbid anxiety, depression on top, or the ADHD, something else that actually is quite clearly separate from the other and should be managed differently, but your brain's set on one waypoint.
Diagnostic overshadowing can lead to dismissed symptoms or misdiagnosis.
Because Lily is so complex, when she's sick, she doesn't show symptoms like her brother would, but I know that something's wrong.
Following a standard inquiry process and completing annual health checks can help avoid this. Annual health checks allow healthcare professionals to understand a patient's baseline health and behaviour, making it easier to identify changes early. They support preventative care, including screening and vaccinations, and strengthen the relationship between patients and their healthcare team.
Health assessments and care plans really give us a good way of making sure that the person as a whole is being looked at, and we're looking at all of their facets.
The Comprehensive Health Assessment Program, or CHAT tool, supports these assessments in two parts. Part 1 is a questionnaire completed by the patient with support from family, carers or advocates. Part 2 is completed by the GP and potentially a practice nurse to develop a health action plan and identify any additional services the patient may benefit from.
We go through a whole heap of questions. We might do some observations like blood pressure, do their height and weight, make sure they're up to date with all the immunisations.
Basically, it just sets up a basis of what we're looking for in the next 12 months, whether I need new referrals, things like that. So it's good to do it once a year and make sure we're on top of everything and Lily's getting what she needs to get from the doctors.
Another key focus is making reasonable adjustments. Changes to services and procedures that give patients with intellectual disability fair and equal access to care.
So we have a fantastic admin team, and we also make full use of some of our IT solutions. That means that if we know that certain patients, for example, are going to need longer appointments, it's automatically flagging them so that they automatically get booked for the right length of times of appointments. If somebody has particular sensory needs, for example, we always, there's a flag on their notes as well that they'll be popped in an empty room to have a quiet wait, unless, it's the very end of the day or very beginning of the day as well. So there's less people around, it's less busy.
So making sure we know our patients, they can highlight something that may be a trigger for that patient, such as if it's going to be a noisy area or there's going to be a wait for their doctor, we highlight that from the start so they know what to expect and what's coming next. And those little changes, okay, would you like to sit in the waiting room? Would you like to sit in a private room? We do acknowledge that not all GPs can do that, but simple changes, your doctor's running 5 or 10 minutes late. Do you want to sit in your car and we can give you a call when we're ready? We have different chairs, fabrics, we have toys, we have fidget spinners, all those sorts of different coping mechanisms that will help someone feel relaxed in our space.
Communication is a key reasonable adjustment. Healthcare professionals can ask patients about their communication preferences and adapt accordingly. Speaking directly to the patient using plain language, focusing on one topic at a time, and allowing time to process information all make a real difference. The teach-back method is a simple way to confirm understanding, helping the person attain information and involving them in their healthcare.
Speaking to the patient and not the support. If someone doesn't speak back, people just generally think, I don't need to speak to that person, but they're here themselves. So you speak with the person, not for the person.
Just acknowledging Lily in general. There's a lot of people that, because she doesn't talk back, don't actually talk to her. So just having that conversation with her and acknowledging her is all you really ask for.
You've got to treat them like they're no different than anybody else. You don't look at the fact that he's got a disability. His disability doesn't rule him. A lot of places they go to, they talk to him like they don't understand. Well, he does understand, only too well what's going on.
Partly it's about looking at communication and also learning your individual patient's communication. So some patients are non-verbal, but you soon get used to, once you've known them for a while, learning to read their body language and to know what to look for in terms of if they're uncomfortable or what symptoms it might be normal for them or not normal for them. So it's looking at the whole body for people who can't always articulate how they're feeling or their thoughts clearly.
It's more being aware of your language and what's coming across, and instead of just letting things naturally flow out, there was a bit more of that conscious awareness of what terms you're using and what they might actually be understanding from what you're saying, and getting it bounced back for what are you understanding.
Where needed, resources like easy read materials or visual aids can also help.
So some techniques we use for Kobe to communicate with him are visuals. So we have pictures telling him, okay, we're going to go, we say we have a picture of the doctors. We say, okay, we're going to do this. And then after that, we'll go and get a treat. So I'll have a picture of a shopping centre.
I do make a lot of use of images because a lot of people are not necessarily verbal. A lot of people are very visual. So if you can then explain what you're talking about and why, combined with the picture, and talk through it, often you'll find they have a much better understanding of what's going on with their health. If they have a better understanding of what's going on with their health, the more likely they are to buy into their health, the more likely they are to follow through on the things that you're suggesting that we're doing, and they're more likely to have better outcomes.
As healthcare professionals, we can all help ensure better outcomes for patients with an intellectual disability by implementing these simple, practical changes.
Don't make any assumptions. You pick up a lot of stuff about what might actually be going on just by listening, rather than just asking a couple of questions and making some assumptions.
They all think you are angry girl. I love all the sport. I love